Right, good afternoon, guys. I hope you guys are okay. Welcome back to the bootcamp series of mock. So today we're going to do part A mock as usual. So we're going to do about 15 questions today. I'm sure most of you know me by now. For those who don't, I'm a cardiac surgery registrar in London. At the same time, I'm finishing my PhD at the Imperial College London as well. So I will be doing the mock together with you. So I've been doing these mocks since 2019. So that's going to be about 7-8 years now. We did mainly part B mocks, but we started part A mocks earlier this year. So these are completely free, obviously, and these will completely be free for the next foreseeable future as long as I can do it. Great. So AI-powered preparation portal, it's coming soon. And if you're taking the exam in January, unfortunately, it's not for you because you won't be able to make it in time. But if you're taking the exam later on in April, then probably it would be a good idea to keep an eye on as well. So subscriptions, when we launch the portal, you see them. But this, I can guarantee you, this is one of the best learning experience that you'll ever have. So once we have the pictures for this portal, I will share you in the group soon. So will you pass the MRCS Part A exam? Well, it's a bit difficult question to answer, but we have released a list of full-length mocks exam. So if you want to go and check it out, I can probably show it to you here. Sorry. So let me open up the new tab and sorry, MRCS bootcamp.com. So if you go there, if you go to the part A, and if you go to the mock exams here, you will be able to take your mock as well. Of course, you need to log it in. I haven't really logged in. So go and check it out. And there are full-length exams, and that is the answer. So many people ask me, especially if you're taking the exam in January, it's a good time that you need to do a mock before you go into the real exam. Real exams are very expensive. So nowadays it costs over £600. So please make sure you take a full-length mock before you enter the actual exam. That's the whole point of it. All right. Without further ado, let's crack on. So I'm just going to close this one. We don't have the Part A portal yet, so we're just going to borrow the Part B portal. So all these portal will be updated to the new version soon. So during the mock, it will be very simple. I'm going to show you the question. You tell me the answer either by unmuting your mic, or you can just type in the chat as well. All right. A 6-year-old child who was playing with his father at a pig farm developed bloody diarrhea and painful red nodules on the limb. Surgical laparoscopy excludes appendicitis, revealing a normal appendix. What is the most likely causative organism? Yersinia enterocolitica, Staphylococcus aureus, Campylobacter jejuni, E. coli, and Amoeba histolytica. Which one?
It's a yes in a
Yersinia.
however you say it.
Okay. Any other answers? No? Right, Ken. I want you to interactively participate in this session. All right. This is not I'll teach you listen session. We'll be doing it together. So sorry, back upon. Yes, of course. The answer is Yersinia. What gives it away? So this is mainly exposure to pigs. That's very, very important. Because Staphylococcus aureus, it's a skin flora. It doesn't usually cause deep infections, unless in certain cases as well. Campylobacter, but again, this is more like exposure to the poultry, like chicken, not necessarily for pigs. So that's why Yersinia is more likely. And E. coli, this can cause very serious infections, but this is not the case in this case. Again, E. coli is not really associated with the pigs either. And Amoeba histolytica, again, this is not linked to the pigs, but this is linked to, this is not linked to the erythema nodosum either. So farm pig animals, then Yersinia enterocolitica would be your answer. Man sustains a bite injury to his arm during a physical altercation. So altercation is a fight. During a fight, man sustains a bite, human bite. So which one is it?
Echinella corrodens.
Echinella. Any other answers? All right, so bite. So why not Pasturella canis, example? Or Pasturella maltosida? Or why not Valtonella? Or why not Staphylococcus bovis? So again, don't try to memorize these things. But of course, in microbiology, there's a certain extent that you have to memorize these things. But try to make sense of it. Echinella corridans, where is it normally found? Do you know? There's the correct answer, by the way. So Echinella corridans, where is it usually found? Anyone? And why would someone have a bite injury during a fight? Normally, well, people don't bite, you know. It's a fist, clenched fist fight. So why would a person have a bite injury? Does anyone know? The answer is very simple. Somebody punches the teeth rather than actually being bitten. Somebody punches the teeth, and that causes the same bite, so-called bite injuries. So Echinella is a normal flora inside the mouth, and it's predominantly causes infections. So that's why in the MRCS exam, if you see human bites, then Echinella corridans would be the answer. Why not the other bites? How about the other bites? For example, cat bites. Cat bites is usually caused by Pasturella maltosida, and dog bites are usually Pasturella canis. So these are the bites organisms that you need to know. Right? And Bartonella usually is associated with the scratches. That's why the common and very famous disease is the cat scratch disease, which is a granulomatous disease, could be triggered by Bartonella after the cat scratches as well. Streptococcus bovis, it's an organism found in the colon. And when you see strep bovis, what you need to know is colon cancer, because due to the colon cancer, this usually causes translocation of the Streptococcus bovis into the bloodstream and then causes infective endocarditis, for example. Right, 60-year-old woman presents to the emergency department with abdominal cramping, fever, and diarrhea. The symptoms begin 12 hours after eating a breakfast of fried eggs and sausages. Stool microscopy reveal fecal leukocytes, and culture on Hactoan enteric agar bacterial colonies with black centers. What's the most likely organism? 12 hours, fried eggs and sausages. Well, even if you don't know about the Hactoan enteric agar, there's something to do with enteric organisms causing diarrhea. Abdominal cramping, diarrhea, 12 hours after eating breakfast and sausages. What's the answer? Anyone? A, Campylobacter jejuni. Any other answers?
A also.
A or C, which one is it? You can't choose A or C in the exam, can you?
And
So
the
choose one.
bacteria.
Campylobacter, okay? Does anyone say Salmonella?
Yes, it is Salmonella because patient very yes.
By the way, Entamoeba histolyticum, Streptococcus pyogenes, E. coli, these are not very likely organisms. So you probably be down with two choices, which is Campylobacter jejuni and Salmonella, and both of them can produce a very similar clinical scenario like this. But I would go with Salmonella, of course. Why? Because of the intubation period. For example, intubation period is much longer with the Campylobacter jejuni. It's going to be a few days, usually about 3 days in advance. It's a longer incubation period, Britain has 2 to 5 days. But again, these can be caused by any of the organisms, Campylobacter, Salmonella, depending on a very slight change, it could as well be the other answers as well. But E. coli, Streptococcus, and Amoeba histolytica, they are not very, they don't really fit the clinical scenario for that. But especially the the well, to be fair, both of them are associated with the poultry and this abdominal cramps and the fever and the diarrhea. But as I said, not 12 hours, but more than 2 to 5 days, so just a few days. All right, I think this is an easier one. 59-year-old diabetic woman undergoes an abdominal ultrasound for recurrent abdominal pain, which reveals gas in the bladder. Gallbladder. Which of the following organisms are most likely cause? Bifringins, Clostridium bifringins, E. coli, Bacteroides, Klebsiella, Campylobacter.
Gas membrane due to the Clostridium perfringens.
Of course, well, I've highlighted to you. The keyword is the gas in the gallbladder. So pneumobiliary complications are usually due to extreme gas-forming bacteria. Right. What is the most common cause of cholecystitis? Anyone? Would have been E. coli. Right. So again, I can slightly change as an examiner, I can slightly change the question and it will change the answer completely. So it's better for you to understand the principle. Don't try to memorize things. However, it's not really associated with the gas-forming bacteria. So gas-forming bacteria is the Clostridium, especially Clostridium perfringens. Right, keep that in mind. Bacteroides, very, very common in the intra-abdominal and the pelvic collections, abscesses, it's an anaerobe. And then Klebsiella, Campylobacteria is more like gastroenteritis and causing fever and diarrhea, as we previously said. It doesn't usually cause, it's very, very rarely cause the gallbladder problem. Klebsiella can cause biliary infections, Pseudomonas, Klebsiella, but again, it's not associated with the gas formation and such. So Clostridium perfringens is the answer. 43-year-old man is diagnosed with bacterial infective endocarditis. Cultures shows sensitivity to amoxicillin, but he's got penicillin allergy. Which antibiotics would he use? Anyone? B, linezolid. B, linezolid. Any other answers? Well, obviously A cannot be right because amoxicillin, he's got penicillin allergy, so A is out. How about cephalosporins? Or cefuroxime? Why not cefuroxime? Why not gentamicin? Especially cephalosporins, why not? Anyone? So for the purpose of the exam, I would go with a safe choice, which is the linezolid. But in reality, it's not linezolid. I'll tell you about that. Why? Because penicillin allergy depends on the extent of the allergy the patient's having a reaction to. Because in reality, the second line is usually cephalosporins. It may cross-react with the penicillin allergies, especially with the patients with penicillin allergies, especially, as Emma said, structural similarity, that is very correct. But it's not the penicillin ring that we thought it used to be. So, in fact, in reality, in clinical practice, we think about what happened during the penicillin allergy. Is it a rash? If it's a rash, then we're going to go with the cephalosporins. Maybe cefuroxime, but cefuroxime, we don't usually use it for the infective endocarditis. We usually use it for the intra-abdominal coverage and stuff. So other class of other choices of cephalosporins, we can go with it. For the purpose of the exam, just to avoid cross-reactivity, usually the classic textbooks would teach you there is about 10% cross-reaction between the amoxicillin, penicillin class and the cephalosporins, but in reality, it's much lower. If it's a severe reaction, if the patient's had anaphylaxis reaction, loss of airways and stuff previously with the penicillin allergy exposure, we will definitely avoid cephalosporins. Or if the patient's had a rash, diarrhea, other mild effects of penicillin allergy, we would go with the cephalosporins in reality. For the purpose of the exam, just go with the linezolid, which is a solid choice. 22-year-old man presents with a wound on the lateral forearm that becomes erythematous with rut, tender streaks 2 days later. Which organism? Oh, we've got a lot of microbiology today. All right, which one is it? Staphylococcus aureus, Streptococcus pyogenes, Bacteroides, Clostridium difficile, E. coli. If I were you, I would cross out E. coli and the Bacteroides, as well as the Clostridium difficile, because probably these are not quite right. E. coli, Bacteroides, these are commonly caused infections in the intra-abdominal infections and the GI tract and the biliary tree. E. coli can cause urinary tract infections as well. Clostridium difficile is the infection for which condition? Anyone? Clostridium difficile causes which type of infections? Very good, pseudomembranous colitis. So it causes pseudomembranous colitis. So it's out as well. So we've got strep pyogenes and Staph aureus. And of course, the answer is strep pyogenes. You know what? Because there are tender streaks around it. If it says kind of like a lookalike, kind of like a bit of pus, then I would go with the Staphylococcus aureus, because Staphylococcus aureus, it causes localized abscess. On the other hand, group A Streptococcus species, like Streptococcus pyogenes, can cause lymphangitis. And that's why you see these kind of like tender streaks, which are in fact inflammation of the lymphatic channels towards the lymph node. So in this case, if the forearm, then it will be draining the axillary lymph nodes. And if you examine the patient, you would see the lymphadenopathy in the axillary lymph node groups as well. A 23-year-old male presents with 4-day history of abdominal pain. Ultrasound reveals a complicated appendicular mass containing purulent material. Which of the following organisms would likely to be found under the microscope?
Bacteroids.
Okay. Any other answers?
Bacteroids.
Very good. So it's a very established fact. By the way, you can find one other organism in these cases. What would that be? Does anyone know? I'll be very impressed if you know about it. It's not listed here, but one organism will almost always be found together.
E. coli.
Very good. E. coli. In fact, E. coli is more commonly found in these conditions together with the Bacteroides. But because E. coli usually consumes all the oxygen available in that local abscess, that Bacteroides, it's a strict anaerobic gram-negative. So with oxygen, they can't really survive. So E. coli used up the oxygen, and that's how Bacteroides survive, flourishes in these abscesses. So any intra-abdominal collection, abscesses, I would go with the Bacteroides for that.
Well,
But the other,
a superficial surgical infection after emergency appendectomy, then what will be the organism?
so say it again.
If patient is having superficial surgical infection after emergency appendectomy, then the organism will be Staph aureus or E. coli.
So it's a little bit difficult question because it could as well be the E. coli. I'm going to go with the E. coli. If you're talking, well, the infection, are you talking about the skin infection or the infection inside?
No, the question is after emergency appendectomy, there is surgical site infection.
Surgical site infection. So
So it
I
might
would go with
be Staph aureus, as it is surgical site infection.
surgical site infection. I'm going to go with the Staph aureus. Right? If it's inside the
Yes.
localized abscess and stuff, then I'm going to go with the E. coli because E. coli is more common. If we're talking about the skin infection, as you said, I'm going to go with the Staph aureus. Right. Next, 54-year-old patient presents with recurrent painful urination, low-grade fever, nitrates in the urine, and evidence of pulmonary fibrosis. Which antibiotics is contraindicated? Anyone?
Very antibiotic contraindicated. Pulmonary fibrosis. Fibrosis.
All right, C, any other answers? Nitrofurantoin is currently a popular choice. Why C? Can anyone tell me?
Pulmonary fibrosis is the complication of nitrofurantoin.
Right, that's correct. That's correct answer, by the way. And nitrofurantoin, unfortunately, what's caused it once you started it, especially in the long term, dose of the elderly, usually in the elderly, long-term dose of nitrofurantoin will lead to low-level chronic inflammation of the lungs. And with time, it would lead to interstitial pneumonitis, and the fibrosis. So the problem is, if the fibrosis happens, it's too late for us to do anything. But even if you stop the nitrofurantoin when the fibrosis occurs, it doesn't usually get reversed because fibrosis is permanent. That's why when there is a lung fibrosis, nitrofurantoin is usually contraindicated. And what do you use? If nitrofurantoin is contraindicated, what do you use?
Ciprofloxacin.
Not really. Usually it is. What is Spectrum?
Tolvector.
Trimethoprim and sulfamethoxazole. All right. So trimethoprim, sulfamethoxazole is usually either the first line or the second line with a nitrofurantoin, depending on the prevalence of the organism. So in UK trust, even in London, some trusts use nitrofurantoin as the first line medication, and Imperial College, for example, Imperial College Trust usually uses trimethoprim as the first line for that. But yes, even if you say amoxicillin, it has got a good gram-positive and negative coverage, but we need a strong gram-negative coverage. Like which organisms are the most common for urinary tract infections, by the way?
E.
Anyone?
coli.
Very good, E. coli. Up to 70, 80, even some texts say 90% of the urinary tract infections are caused by the E. coli. So either trimethoprim or nitrofurantoin if the patient's got pulmonary complications, and we try to avoid nitrofurantoin because of the risk of pulmonary fibrosis. Which of the following structures would you worry about during posterior leg compartment fasciotomy? Anyone? Well, I can see potentially two answers. Potentially two answers, but go on. We'll talk about it in a minute. Some will say A, some will say C. C is peroneus tertius. A is tibioperoneal bundle. All right, okay. A, tibioperoneal bundle. I think the stem of the question is not very complete. Probably it's something's missing from the stem. D, sural nerve. Okay, any other answers? Well, we've got A, D, and C, peroneus tertius. But I can tell you, peroneus tertius is not. It's out. Why? Anyone? Why is it out? As well as tibialis anterior, it's out. And short saphenous vein is out. Why? No? Right. Okay. So it's either tibioperoneal bundle or the sural nerve, depending on what the question wanted to ask. If the question's asking about four-compartment fasciotomy, the most commonly injured structures, I'm just going to go with the sural nerve. If the question is asking about digging deep in the posterior compartment, I'm going to go with the tibioperoneal bundle. Again, do apologize. I think there's a bit of confusion with the question. So if in doubt, just go with the sural nerve because that's more commonly asked in the MRCS level exam. But if you're taking the FRCS, then you would be aiming towards the tibioperoneal trunk. Why? Tibioperoneal bundle, that's the tibial nerve and the tibioperoneal trunk, which will further divide in anterior posterior anterior tibial artery and tibioperoneal posterior tibial artery and the peroneal artery lies very close to the region of the oh, I just forgot the name of the muscle in there. Anyway, so that's a big muscle in the posterior compartment. And if you're going to do the fasciotomy, if you're going to open up the compartment septum, which you must actually do it, very, very important, then you have to identify that bundle so that you don't cut the blood supply and the nerve, tibial nerve as well. Otherwise, the patient will have lots of problems for that. Right, soleus muscle. So let's go. So what? It's a sural nerve. So sural nerve is the superficial structure that could be injured with the medial incision. So when we do the four compartment fasciotomy, I'm sure some of you already done it. Some of you may not have done it, but in my experience, I've done lots and lots of fasciotomies. So we do two incisions, one on the medial side, one on the lateral side. The lateral side decompresses two compartments. Which two compartments are these? Lateral incision. Anyone?
Anterior lateral.
Very good. Anterior compartment and the lateral compartment. When you look at these, short saphenous vein usually lies laterally. So that is for the lateral incision, so it's out. Peroneus tertius lies in the anterior compartment. Again, it's out. Tibialis anterior lies in the anterior compartment. Again, it's out. So these are not usually injured by the medial incision. So we've got two. Sural nerve is a very superficial one that runs on the medial side of the leg together with what structure? On the medial side of the leg. What else runs with a sural nerve?
The great saphenous vein.
The great, I beg your pardon, sorry. I thought it's a saphenous nerve. Sorry, there is a bit confusion here. I don't think that sural nerve it's the correct answer. The correct answer would have been tibioperoneal bundle. I do apologize for that. I need to look into this question and then fix it later on. I thought it's a saphenous nerve because saphenous nerve would be running together with the great saphenous vein on the medial side. So for the medial incision, which will decompress posterior compartments of the leg, then saphenous nerve and the saphenous vein will be at risk. And if you cut the saphenous vein and start bleeding, it's always a headache. Right? But if you dig deeper into the posterior compartment and divide it, and then if you're going to release the deep posterior compartment, remember, there are four compartments. When you do the fasciotomy, you must be able to decompress all four compartments. If you accidentally leave the deep posterior compartment intact, the patient will end up losing the leg anyway. So there is no point of doing fasciotomy. That's why when you do the fasciotomy, be very generous with the incisions and make sure you decompress all the compartments in the leg as well. So the correct answer would have been tibioperoneal bundle for that. I do apologize. I misread as a saphenous nerve. So sural nerve runs on the lateral side, and there's nothing to do with the medial side in incision for that. Which of the following structures would be spared in a patient with anterior compartment leg syndrome? Anyone?
It is in the posterior compartment.
Say again.
Is it sural
E.
nerve because it lies in the posterior compartment?
Of course. Right. If you look at the anterior compartment is the extensor hallucis longus, and this nerve innervating the anterior compartment is the deep peroneal nerve. So this is out. Peroneus tertius. Remember, peroneal muscles are usually in the lateral compartment, but the tertius muscle or the very small peroneus muscle is in the anterior compartment. So this is out as well. Dorsalis pedis, this is the continuation of the anterior tibial artery. So this is in the anterior compartment as well. If there is a compartment syndrome in the anterior compartment, everything will be knocked out. Only the sural nerve is usually located in the posterior compartment, and then will be going laterally and then branches and innervates the lateral surface of the foot and the lower posterolateral part of the leg as well. So 26-year-old man presents to the emergency department with extensive bleeding from his arm following a glass injury. Examination reveals a 7-centimeter cut, transverse cut, across the anterior aspect of the elbow. When exploring the cubital fossa, you'd expect brachial artery to be anterior to the median nerve, lateral to the biceps, medial to the median nerve, medial to the biceps, superficial to the biceps. Bicipital or neurosis, which one is it? B. C. B, lateral to the biceps tendon. C. D. All right. So if we're going to look at the cubital fossa, the mnemonym is, does anyone know the mnemonym? Anyone? All right. The mnemonym is 10, from lateral to medial. So that is T for tendon, A for artery, N for the nerve. So in this case, the brachial artery would lies medial to the biceps tendon, because laterally starts with the tendon and then the artery and the nerve. TAN, 10, is the mnemonym for the cubital fossa for that. But it's a very easy question if you know it. If you don't, there is literally no way that you'll be able to figure it out on its own. Great. Remember, TAN, tendon, artery, nerve, starting laterally to medial. All right, it's a good one. Following a supraclavicular lymph node dissection, a 43-year-old male patient is unable to shrug his left shoulder. Which of the following deformities would be expected? Loss of neck flexion, inability to rotate the face towards the right side, inability to rotate the face towards the left side, loss of sensation over the upper lateral shoulder, inability to shrug the other shoulder.
Inability to rotate the face toward the right side.
Okay. So it's the right side or the left side?
It will be right side.
Why is that?
Due to supply to the sternocleidomastoid muscle.
Okay, what's the function of the sternocleidomastoid muscle? So we now know
Movement of face
sternocleidomastoid
opposite to the face.
Very good. That is correct. And sternocleidomastoid and the trapezius will be supplied by which nerve?
Accessory.
Spinal accessory nerve.
Spinal
11th
accessory.
cranial
Very good. Accessory nerve will supply both. And if one of the most common reasons that I get injured is the supraclavicular lymph node dissection in the posterior triangle of the neck. Once it's a dissection injures it, then it will injure both of the muscles. Usually, well, it says an unable to strike his left shoulder, but if it's purely injured in the lower part of the posterior triangle, usually trapezius is spared, or sternocleidomastoid will be a bit spared as well, because most of the branches would be gone out. Anyway, so in this case, it's a classic scenario. So the left side, his left shoulder, so the left side of the sternocleidomastoid is paralyzed now. Sternocleidomastoid, as the name goes, so it goes from the sternum, clavicle, that's why it's sternocleido, goes to the mastoid process of the temporal bone. Thus, you can see the mastoid process at the back. You can think of all the muscles as the strings. They're literally the strings. They're very thick strings. They contract, meaning they pull the strings. That happens. It's the function of the sternocleidomastoid. If they contract bilaterally, it flexes the neck. So we're pulling it together. If they contract unilaterally, since the hat is on an axis, and atlas and the axis top of each other, and something goes from the front to the back, and if they pull it together, it turns the hat towards the opposite side. So the right sternocleidomastoid muscle would turn the hat to the left side, whereas the left sternocleidomastoid will be turning their hat to the right side, where we are going to find the correct answer. Let me repeat that. Sternocleidomastoid goes from the sternum, the clavicle, the hair anteriorly, and the mastoid process towards the back. So if this muscle pulls there, it turns the hat away to the other side. If those two muscles pulls their unit bilaterally, that would gonna cause deflection of the neck. Great. Loss of one muscle alone does not cause the loss of neck flexion, because there are other muscles, scalene muscles, and the other neck muscles that does deflection of the neck. So it doesn't cause it. Right. Face towards the left side. So this is done by the right sternocleidomastoid, but the injury is on the left side. So that's fine. No, this is wrong. And lost sensation of upper lateral shoulder. So accessory nerve does not have any of these sensory branches. Inability to strike the other shoulder. Again, that's done by the contralateral accessory nerve, which doesn't make sense. So the correct answer is inability to rotate the face towards the right side when the left side is injured. Which of the following muscles is responsible for abduction above 90 degrees at the shoulder? Trapezius, okay. Any other answers? B, deltoid. A, trapezius. Supraspinatus, anyone? No. Pectoralis major, minor. So the correct answer is trapezius. A, indeed. That's good. Tell me the muscles of abduction. So abduction meaning going this way. Right. Starting from here all the way here. How do we do it? Which muscles do it? Initially,
Deltoid.
no.
Initially,
Supraspinatus, very good. The initial 15 degrees is supraspinatus. And then deltoid takes over up to 90 degrees. Beyond 90 degrees, trapezius, and with the help of one more muscle.
Anterior serratus.
Serratus anterior, very good. Trapezius and serratus anterior will rotate the scapula because there is no muscle above our head to pull this head beyond 90 degrees. So the deltoid goes like this. So up to 90 degree deltoid pulls, that's it. Beyond that, how is it done? It's pure miracle, by the way. There is no muscle, no neck muscle to pull this up. So how it's done is rotation of the scapula, mainly by the trapezius and helped by the serratus anterior. So the correct answer would be obviously trapezius. Why the deltoid? Up to except the initial 15 degrees, up to 90 degrees done by the deltoid, but not beyond 90 degrees. Pectoralis minor and the major, these are adductors. These are not abductors. Right? Supraspinatus is the very first adductor for the initial 15 degrees. Subscapularis, again, it doesn't cause the abduction. It's the adductor and more stronger internal rotator of the shoulder. 32-year-old man falls on an outstretched hand. During his distal forearm, 2 centimeters above the wrist, he is unable to lift his thumb off the table with his palm facing downwards. When the proximal phalanx is fixed, he cannot move his interphalangeal joint. This is very important. What is the most likely cause of injury? Abductor pollicis brevis. All right. Any other answers? D, extensor pollicis longus. C, abductor pollicis brevis. Any other answers? C, abductor pollicis brevis. So let's go through this one by one and dissect down to what is possible and what is not. 32-year-old man falls on an outstretched hand. Not good. Injuring the distal forearm 2 centimeters above the wrist, he is unable to lift up the thumb on the table with the palm facing downwards. Lift off the thumb while the palm facing downwards mean which movement of the thumb? Which movement of the thumb is that? Lifting while the palm is facing downwards, lifting off the thumb. It's well, it's a combination of two movements, so it's not pure abduction. Abduction of the thumb is this one, palmar abduction, right? So, well, we can't really do this movement while the palm is facing downwards, can we? So it's more like the extension. But yes, abductors help with the extension as well. This is the very important extension movement is this. Let me show you all the thumb movements anyway, just to revise quickly. Right. So this is our normal anatomical position. This is, I'll show you closer to you.
And that's
This is
flexion.
This is flexion. This is
Extension.
extension. This is
Abduction.
abduction. This is
Adduction.
adduction. And this is
Opposition.
opposition. Very good. So in this movement, if we're going to put the patient's palm down and ask to lift up the thumb, that is a bit of combination of abductor muscles, but mainly the extension. So we should be focusing on the extensor muscles now. Extensor not walking. When the proximal phalanx is fixed. So when we look at the extensors, there are two extensors here. Extensor pollicis brevis and the longus. Which one is it? Because it's not the same. And the second sentence will give you the hint. When the proximal phalanx is fixed, he cannot move the interphalangeal joint. What does it mean? The interphalangeal joint is moved by only one tendon, and that is the one that goes all the way to the distal phalanx. There's only one tendon that goes all the way to the distal phalanx. That would be, of course, it's longus. It goes longer than the brevis, that's why it's longest, right? And that is the way how you can distinguish between the longus and the brevis as well. Great. So just to recap, this movement when the patient's putting the palm down and lifting up the thumb, that is the extension mainly, but abductors help. But as long as the extensors are walking, they'll be able to do that. And if they can't do that, extensors are a problem. The way to distinguish between the longus and the brevis is you fix the proximal joint and ask the patient to move the distal phalanx, meaning interphalangeal joint. If they can do it, extensor pollicis longus is walking, meaning the longus goes all the way there. Because this joint is moved by both brevis and the longus. But the distal interphalangeal joint, no, the interphalangeal joint, I beg your pardon, is moved only by the extensor pollicis longus tendon. Right. The last question. A 34-year-old man suffers a traumatic brain injury to the shoulder following a motorcycle accident. He presents with weakness and sensory deficits in the upper limb. Examination suggests damage to the brachial plexus. So, motorcycle accident, problems with the brachial plexus. Which nerve is most likely to be spared, meaning which nerve is less likely to be injured? Anyone? No? Just give it a guess. Motorcycle accident and the brachial plexus is injured. Which nerve would be spared? So, in other words, would it be Erb's palsy or Klumpke's palsy?
It will be Erb's.
Erb's palsy. What does Erb's palsy mean?
C5, C6 upper trunk is damaged.
Upper trunk will be damaged. I'll give you a very, very simple explanation. All right? Don't try to memorize everything. I really hate memorization, so I try to understand these. Erb's palsy or the upper roots. Brachial plexus runs from here all the way through the axilla and then into the different branches into the upper limb. So if there is this angle between the head and the shoulder, if this angle is stretched too much, it will cause damage to the upper cords. That is something called Erb's palsy. For example, road traffic accident, the man might be thrown onto the road and falls onto this area and causes the stretching of this angle too much. That will cause the Erb's palsy. Or if you are delivering a baby, well, not necessarily you, if a baby is being delivered and you pull the baby's head and the shoulder is stuck inside the uterus and causes the stretching of the head and the shoulder angle, again, that will cause the Erb's palsy, and that will damage the upper roots of the brachial plexus. Which roots contribute to the brachial plexus? Which cervical level?
C5 to T1.
Very good. C5 to T1. C5, 6. Go on. C5, C6, C7.
C8, T1.
81.
C8, T1. All right, don't forget the C8, because there are only 7 cervical vertebrae, but there are 8 cervical nerves there. So yes, so C5 to T1 is where the brachial plexus contributes it. So upper root starting from C1, usually C5, C6. That is the main injury for the Erb's palsy. And that is due to the outstretching of the head and the shoulder. On the other hand, Klemsky palsy, this axillary angle. For example, somebody goes and paints the house on the ladder and the ladder falls. So what they have to do is hang on onto the edge of the window. That causes stretching of this angle, and that will lead to lower roots. This time, lower roots. C8, T1, and that is something called Klemke's palsy. Same with the delivery. If the baby is being delivered and at this time the baby's hand is pulled out, as a result, causing outstretched of the axillary angle, that will cause the Klemke's palsy. Or C8, T1 palsy, that is a very, very lower roots. Coming back to this thing, so it's a very, very vague MCQ, but if we're going to look at the brachial plexus damages and it's going to damage, do you think he is more likely to fall onto this angle or versus he will be hanging onto something in a road traffic accident? Of course, he will be falling with outstretch of this angle, and this will starting to damage from C5 all the way to C5, C6, C7 probably. C8 may be injured, but most likely to be spared because C8 is too deep from this angle of injury. So which nerve is most likely to be spared? C8, T1. Which nerve is that? Which nerve comes up from C8, T1? Of course, it's the ulnar nerve. Right. Even if you don't know anything, if you understand these kind of mechanisms of injuries and stuff, you can easily navigate through these MCQs. As I always say, do not try to memorize these things. Right? These things will come from all different directions. As long as you understand the principles, you'll be able to do fine. Great. So this is pretty much of it for today's mock, and thank you for coming to attending. I've got part B mock coming up soon, so have you I wish you best for the rest of the weekend. Hopefully I'll see you next week. Okay, thank you and